Hello, everybody, and welcome to the virtual online version of our plan of correction training. This is just going to be a real quick training to go over the new requirements related to our survey that we had the beginning of January for our ACHC accreditation. This is similar to Joint Commission or CHAP accreditation. The company that we used was ACHC. We did have our survey January 3rd through January 4th. And so these are the requirements that we have to make changes about related to that survey. So I'm going to go over those here. So we did receive 5 total deficiencies on our survey. Really, it was 4, but one of the issues basically split off into 2 different regulations. So they gave us 2 separate tags for the same issue. So in total, we had 5 deficiencies. All of them were single instances, very minor. None of them were patient safety related. Overall, we were very pleased with our survey. So was the accrediting organization. There's absolutely zero follow-up they have to do with us. We are accredited, but like I said, they did want us to make a couple of procedural changes. So we're going to go over that with you guys here. These changes are effective immediately. So as of Wednesday, February the 16th, going forward, any documentation or visits that you're doing have to meet these guidelines in this training. We're going to monitor our compliance via our QAPI program. This will be a combination of a chart review, home visits, and our QA team working to monitor that we're making these changes in our clinical operations. So jumping right into it, number 1 is going to be ACHC regulation HH56A. So this is not a condition of participation, nor does it have a federal regulatory tag. So it is simply an ACHC requirement. However, we do have to meet it. So the deficiency was that we were not documenting the discharge instructions that we provided to the patient and caregivers on our discharge summaries. So we have to document what instructions were provided to those patients on our summary, not just our visit, in our summary. And so the way we're going to meet this requirement is I've built 2 separate templates. For our nursing staff, you're going to use template DHH DCSN narrative. So if you'll just type in your narrative section of your OASIS, so it's the very last page of your discharge, the very bottom section where you type your visit narrative, it has to go there so it'll flow to the summary. Okay, so you're just going to insert the template, type in DHH. Those are all of our individualized agency templates. Start with DHH, DCSN narrative. And so that's going to pull up the narrative for your visit. And it's also going to list all the discharge instructions that come directly from that discharge instruction handout that's in the patient's home folder that we go over with them at DC and leave in the home. So make sure that you're inserting that template. Make sure that you're reading the template to make sure that it makes sense and that you've filled out all the applicable spaces that require you to fill it out. So it's nothing big, nothing hard, but that template now has to go on all of our discharge summaries. So for my QA team that's listening in, you're looking for DC instructions on DC summaries. So that's going to be all summaries, all disciplines. So for my physical therapy squad that's listening in, you guys are also going to be inserting, when you're doing your discharge summaries, the template DHH therapy DC instructions for DC summary. So you're going to put that on the discharge instructions section of your PT discharge summary. So once again, my QA team, you guys are going to be looking for that template as well. So pretty easy stuff there. Moving on, number 2 is HH5-2F, and that's regulatory tag 48455C5. So we had an instance where the clinician that did the start of care did not list the dosage of the aspirin the patient was taking. So that's an easy fix, guys. We just have to double check our work whenever we're entering medication. So the requirement is medication profiles should contain all current medications the patient is taking, the date it was prescribed or taken, the medication name, dose, route, frequency, the date discontinued, and any drug and or food allergies that the patient has. So nurses, we're just double checking our work and making sure we have all those requirements for each medication that we put on the med profile. QA team, I need you to make sure and back them up and make sure they're doing those things as well. For my physical therapist, really for you guys don't really do much with meds, but you do perform a very important role, especially for therapy-only patients, that we keep a correct and current medication profile. So you guys at each visit should be asking the patients if they've had any changes to their medication regimen, any newer changed meds, any discontinued meds. So make sure that you're questioning the patients and caregivers at each visit. If they do have a change, make sure that you fully report that change to the patient's RN case manager as well as the clinical manager. So what you're reporting to them is all the things that are listed over in the nursing column. Make sure if the patient starts a new medication that you tell us when they started it, what it is, the dose, the route, the frequency, how long they're supposed to take it. Or if they have any new allergies, so we can document that. The RN case manager will then update that medication profile, which should flow automatically to the plan of care. So this one is just, it was a simple mistake. It was not typed in there. So I know you guys all know how to write medication profiles and meds on plans of care. So just make sure that we're doing that and double checking our work. So this is part 2 of that same deficiency. This is the one that's split off into 2. It's HH5-3A, regulatory tag 484.60A2. So it was that there was no aspirin dosage on the plan of care. So simply by default, because it was not put in correctly on the med profile, it did not flow to the plan of care correctly. So we got 2 different dings for the med profile and for the plan of care. So once again, the plan of care should contain all those things listed there in the nursing column on this slide. Same thing for my therapy team. No changes from this slide to the last. So it's just those things do flow automatically to that plan of care. So if there's a mistake on one, there's going to be a mistake on the other. So just make sure that when we're putting in meds, when we're questioning meds, those kind of things, we're double checking our work. QA team, same thing. Okay. Number 4 is HH5-3C-48460E1. There was no copy of written instructions provided to the patient and caregivers per our agency's policy timeline. So what our policy says is that we will provide written instructions by the 2nd visit following the plan of care approval. So what we were doing previously is we were printing out the plan of care in the med profile and taking it out to the patient home. That was our way of meeting that standard. The problem is the plan of care is approved at start of care by the physician. We put that statement in there that the physician approved the plan of care. So that means by the next visit, we've got to have the stuff out in the home. Well, that is never probably going to happen because it's simply not ready yet. It has to still go through coding in the QA process. So we have to make sure that we have something to cover us in the interim. So what we've done is we've come up with a couple of forms that are now in the patient's home folder. So the form that you're going to be using is in section 5 of the patient's home folder. The admitting clinician, the admitting RN, is responsible for getting that piece of paper out of the section 5 of the home folder and filling it out and putting it in the very front of the patient's home folder. So it's a form that you fill out. It's basically says, my nurse is, you put the RN case manager's name there. My therapist is, put the physical therapist's name there. And then you put your frequencies. Now, we're not going to write a traditional frequency. We're going to write this in a language the patient can understand. So if the patient's going to get nursing for 2 weeks, you're just going to write once weekly for 2 weeks. My physical therapist, sometimes you don't always know your frequency. So I want you to write 1 to 3 times weekly for 4 to 6 weeks. And so that'll cover you guys as far as with your frequency in the interim until we can get the plan of care out there. So you're also going to nurses, you're going to fill out, nurses and therapists are both going to fill out the middle section, which talks about what we will provide to them. And so it's a 1-sentence statement that tells what we're going to be doing for them. The nurses are going to teach them about their disease processes, assist them with their surgical wounds, just a brief statement of what nursing is going to be doing. Physical therapists, so you also have to fill that in. My evaluating therapist is responsible for filling that in. Education on a rehab program as well as a home exercise program would be sufficient. So therapeutic exercises, home exercise program, just a 1-sentence blurb in that middle section talking about what we will do for them. The bottom section talks about medication. So the bottom of that form, it says that a list of your medications has been provided to you. We'll get to that in a second. And that the patient will self-administer all meds except. So here's where my admitting RNs, you would fill out any drugs that we're going to be delivering or administering to the patient. So the only thing I can think of that would really apply would be like a Rocephin injection that we're coming out and doing maybe 3 or 4 days in a row. So you're going to list only drugs the home health agency is going to administer. The patient should self-administer. The second form that's going to be now in your admit pack is a blank medication profile. that needs to be filled out and left with the patient in their home folder. Make sure you show them where it is. Also, make sure that you sign and date it. It has to be a complete medication profile. So it has to have all of the things on it that medication profiles require, such as drug allergies, when the medication was started, patient dose, on, et cetera, et cetera, et cetera. So you're generally writing these things down anyway. My suggestion to you would be to write it down on this form and take a picture of it with you to come back and enter into the software. So if the patient has a good discharge med list from the hospital, I'm fine with you guys using that for the patient's medication profile in lieu of the form you fill out, as long as it meets the requirement, as long as it has allergies listed, as long as it has when the medications were started, it's complete and correct. You have to also sign and date it. So I went over that in case conference this morning with the staff as well. It's okay if you want to use that, but make sure that it meets all the requirements. So those two things are new additions to the home folder. So the form is in, that should say section 5 of the admit pack. Disregard that, it's a typo. We're also going to continue to send out that plan of care summary to the patients, but it's sometimes 2 to 4 weeks behind. So these two forms will cover us in the interim. Therapy, make sure that you're getting that paper, filling out the blanks that are for you as well. Everybody make sure that you're checking your box here in the office regularly for the printed copies that need to go back out to the patient's home folders. For my people that are in far off places, for my contract therapy companies, those will be sent to you to take out from your home office, wherever you originate from. So if you have any questions on this, feel free to come see me or call me in the office here. Those forms are in those home folders effective today. You'll start seeing them in the new home folders that show up. We're only doing this from today forward. We're not going to go back and try to fix old problems. Today's our effective date, which is Wednesday, February the 16th. Okay, our last one, number 5, is HH7-1A, Federal Tag 48470A, which is infection prevention. So we had a couple of breaches in our standard precautions and infection control protocols at one of our home visits, and so they did cite us for that. So I just want to make sure that you guys are just up to snuff on what exactly we are requiring of you in regards to infection control. We're not really going to talk about COVID here. That's for a different day. Basically, standard precautions are in play. So the standard precautions are that you use gloves whenever there's a potential for coming into contact with something infectious or blood, waste, or body fluids. Also that you clean your equipment thoroughly between uses. That includes between person to person. So, right now with COVID, so we weren't going to talk about it, but we got to. With COVID, we have to screen everybody in the home. So the instance that we were tagged on here was the admitting clinician checked the temperature of the patient, did their screening, and then walked over and did the caregiver screening and didn't clean her thermometer in between the two uses. And it was a forehead thermometer that you actually touched the patient. So that was considered a breach in standard precautions, because one of the elements of standard precautions is that you clean your equipment between person to person use. Okay. Also make sure that we're using barriers. Okay. So we have to use barriers for just about everything. One of the new things with ACHC is your bag in your car has to be on some kind of barrier. So you can't just set it in your trunk, set it in your floorboard, set it in your seat on the actual fabric, carpet, leather, whatever. It has to be sitting on some type of barrier. Now, you can use a trash bag, you can use a Rubbermaid container, you can use a plastic lid. It doesn't matter to me, as long as it's sitting on something. Make sure that it has a designated barrier place for it to sit on. You also have to use barriers in the home. That bag has to sit on a barrier if it's going to sit somewhere in the home on one of their surfaces. So put it on a trash bag. You have to put your items that you're going to use on the patient on a barrier. You can't just lay them out on their bedspread or wherever you're trying to go to do their visit. You have to use a barrier. If it's not your bag, your nursing bag, your therapy bag doesn't count as the barrier. So you lay your equipment out on your barrier. Make sure that you're not laying clean things next to things that have already been used. So if I'm going to use 3 sets of gloves, I use a set of gloves and I take them off. I'm not going to lay them right down beside the clean gloves I have laid out to use. I'm going to put them probably in the trash bag or on a separate barrier. Make sure there's a very clear separation between your clean things and your things that are considered dirty. Cleaning your equipment. We clean equipment in between every patient use. We cannot use spray to clean our equipment. We have to use a wipe. you have to allow the equipment to dry before it goes back into your bag. So if you check vital signs at the end of your visit, probably going to want to make sure that happens at the beginning so the stuff has time to dry on the barrier. Using a clean field for any type of procedure. So blood draws, wound care, make sure that you're using a clean field, a wax barrier, a new trash bag, something to lay down to create a clean field to put your supplies on. We do have small trash bags here in the office for you guys to use. So you're welcome to come by and grab some. Or you're welcome to provide your own, but we do have that here for you if needed. The January in-service is about infection control, so that should be coming out soon. So make sure that you're going to see that. We're just a little bit behind on our January in-service, so that'll be coming out soon via email to do online. So just make sure that you're seeing that. Okay, so like I said previously, we are going to monitor compliance of this. We're going to do this multiple ways. We do expect you guys to start doing these things right away. So clinicians, we want you to self-monitor. Make sure that you're doing these things. Your patients should get used to you doing these things. These are best practices. This is not just, oh, something else Missy's asking us to do is so dumb. We'll just do it whenever she's with us. These are really things that we need to do to protect our patients and to provide good care for them. So make sure that you're doing these things effectively and, check yourself. We are going to be doing home visits just to verify that I do have to measure metrics about how we're doing with our plan of correction. So we're just going to do home visits to verify that we are meeting our goals of compliance, which are 95%. The QA team is going to be doing chart review for us to make sure that we are also meeting these requirements in our documentation. And then also, survey activity. The accrediting organization can always come back and monitor us. They will look for these things at our next triennial survey, which is due in 3 years. Okay, so for our next survey, obviously our target is 0 deficiency. So we want to make sure that we are making corrections now, and we should be in good shape. And that is all I have. So just make sure that you guys are doing these things that we talked about here today going forward, and we won't have any issues. If you need me, have any questions, concerns, issues, things you need to talk about, of course, I'm always available to you guys. Just shoot me an email, shoot me a text. Be glad to visit with you online, via phone, or in person anytime. So you guys have a great day. Thanks for listening in, and we appreciate all that you do.